Okay, good morning. Thank you all guys. Today is the last day for transferring live case to mainstream 360. So I think today is also the conclusive day to finalize the transmission for pilot session. Today we will have two cases, coronary cases with very complex lesion. So now is the first case from Nanjing First Hospital. Dr. Ge and his colleague is ready. So go ahead to introduce the history of the patient.
Okay, thank you, Professor Chen. And I'm very honored to here to navigate for the midstream 360. And first of all, I want to introduce our team. Is on my right is Dr. Gou and Jerry and the nurses and the image technician Dr. Pan. And firstly, I would like ask Dr. Gou to introduce this patient clinical information. Thank you, Dr. Gou.
Thank you. It's my honor to introduce this case. Next. This patient is 82-year-old female. She was admitted into our hospital due to sudden chest pain for 1 month. This patient received prior PCI due to acute myocardial infarction or anterior wall on May 23rd, 2023. She suffered from essential hypertension for several years. Lab test at our hospital showed her renal function was almost normal. BNP was slightly elevated. ECG found T-valve inversion in leads V1 to V6. Echo found abnormal motion of anterior wall and her left ventricular ejection fraction 55%. She was diagnosed as unstable angina or MI and essential hypertension. Next. This patient, 1 month ago, this patient received emergency coronary angiography due to acute myocardial infarction. The baseline angio showed only mild stenosis in right coronary artery. Next. From AP cranial view, we could find diffuse severe stenosis in LAD because ECG found acute myocardial infarction or anterior wall. The lesion in LAD was the copper lesion, so 2 drug-eluting stents were deployed in LAD successfully. From AP core view, we also could find severe stenosis in from proximal to distal left circumflex involving obtuse marginal branch, very big, large obtuse marginal branch. It's Medina 011 bifurcation lesion. Next. The QFR for left circumflex is only 0.65. Is significant ischemia. Have an indication for coronary revascularization. Next. A stage trial designed by Professor Sao Liangcheng aims to explore the optimal staged interventional strategies for acute for STEMI patients with multivessel disease. This patient was enrolled in stage trial. For this patient, she was randomized to out hospital stage PCI group. She will receive a stage PCI around 30 days after prior PCI. Next. Syntax score for this patient was 24, according to definition criteria proposed by Professor Sao Liangcheng. This bifurcation, left circumflex obtuse marginal bifurcation belongs to complex bifurcation lesion. Next. Our strategy, we plan to perform IVUS-Guided PCI according to ultimate trial. For complex left circumflex obtuse marginal bifurcation lesion, we plan to perform DK crush according to definition 2 trial. That's all. Thank you.
Okay, thank you, Dr. Gou. Introduce the patient and clinical information. And this patient, summarize this patient. And today's target lesion is circumflex and OM and bifurcation lesions. From the angio, today's angio shows on the screen. Yeah, this from the angio we can see the LG's stent is expansion very well, and the circumflex, approximate circumflex is significant stenosis with the severe calcification, and circumflex and OM is the 2 bifurcation lesions, and we can the OM is bigger vessel and circumflex and bifurcated 3 branches and we can see the circumflex, distal circumflex is diffuse lesions, but it's not big vessel. And so I want to use the IVUS to assess this lesion and to decide what the strategy to do. And so next. So next. Okay, so we did the IVUS for the OM and the circumflex. And first, before that, we used the 2.0 and semi the compliant balloon to pre-dilate, use the low pressure pre-dilation, and check IVUS for the circumflex and OM. And Dr. Pak, can you interpret the in IVUS imaging?
Okay, let me show the IVUS imaging. The first one, we check IVUS from distal circumflex to proximal circumflex. And here we can see the distal vessel is very small. The vessel diameter is just 2.0 millimeter. Then go and pull back, we can see eccentric plaque. And go and pull back here. This point we can find this is the minimal lumen area. The area is just 1.5 millimeter square, and the plaque burden is about 60%. Then go and pull back. Here we can see find the bifurcation. Here this is the PL and the circumflex bifurcation. The netness from the distal landing route to the circumflex and the PL bifurcation is 20 millimeter. Then go and pull back. Here, this point we can see find the standard landing route, and here the vessel diameter is about 3.5 millimeter, and the lumen diameter is about 2.75 millimeter. Then go and pull back. Here we can see eccentric plaque, and go and pull back. This is near the circumflex and the OM bifurcation, and here we can see the guide wire. Then here this is the bifurcation. This point, the area is about 1.8 millimeter square, and the plaque burden is more than 75%. The netness from the standard landing route to LAD and the circumflex and the OM bifurcation is just 7 millimeter. Okay, the second round we check IVUS from the distal OM to left main, and here we can see the distal vessel is normal. The vessel diameter is about 3.0 millimeter. Then go and pull back, we can see eccentric plaque. Then go on. Here, this point is the minimal lumen area. The area is just 1.6 millimeter square, and the plaque burden is more than 80%. Then go and pull back, we can see the circumflex guide wire. And here, this is the circumflex and the OM bifurcation. Then go and pull back. This is a proximal circumflex. The proximal circumflex, the plaque burden is very large. And here, this point, the area is about 2.0 millimeter square, and the plaque burden is more than 88%. Circumflex. Then go and pull back. We can see this is a Austin circumflex. This is a LAD. We measure the netness from the distal landing route to circumflex and the OM bifurcation is about 12. And the netness from the distal landing route to the ostium circumflex is about 41 millimeter. Okay, this is the baseline IVUS imaging. Thank you.
So from the case introduction, actually the patient suffered acute myocardial infarction 1 month ago. So Kajan, do you have any additional information about the primary PCI procedure?
Yeah, it's a great point. Is a patient is 1 month ago again suffered the acute MI for the anterior wall. So we did the primary PCI for the LD, and for the stage of PCI we have the data, and complex revascularization is better than the complete only revascularization. So for the select the PCI for the non-comparative lesion revascularization, what time to do this, and we have no data to guide us. So it's the stage of trial is to compare this select the PCI for the in-hospital stage PCI or out the patient, out the hospital the PCI for this non-comparative lesion revascularization. So for this patient, we randomize into the out hospital stage PCI. So today we will treat this non-comparative vessel.
In general, almost 25 to 30% of patients with acute myocardial infarction have the multiple disease. So the complete revascularization for non-corporate vessel is a challenging issue. The two studies report the benefit of in-hospital stage PCI. It means the time interval between primary and stage PCI vary from 1 day to 7 days. And another two study reported the benefit of stage PCI, which was done after 1 month, between 15 to 30 days. So this is why we need to design stage PCI to compare the different time point of stage PCI to benefit the patient with acute myocardial infarction. So also in terms of the study trial after primary PCI, for non-corporate vessel, we need to calculate the QFR. If QFR is less than 0.8 in non-corporate vessel, so we need to randomize the patient into two groups. From the baseline geography just after primary PCI, so the QFR for proximal circumflex was only 0.65. So this is very strong evidence to support the stage PCI for circumflex. On the other hand, the QFR at the distal circumflex is about 0.39. Is that correct?
Yes.
So I think this is a very important thing we need to introduce to our audience why we need to do stage PCI at 1 month interval after primary PCI. So for this patient who is very old, 82 years lady, so in general, I think before the procedure, then I have a few questions.
Okay.
The first one, why did you choose transradial approach but not transfemoral?
Yeah, because this very old lady, and because from the radio access to the PCI, probably from the previous study, maybe to reduce the bleeding, the complication. So for this patient, we use the radio access.
Yeah, actually, the benefit of transradial approach or transfemoral approach has been confirmed by several randomized trials and observation study. One trial a few years ago published from Fire Hospital report transradial approach was almost used in 85% of patients during our daily practice. Secondly, a transradial approach leads to less rate of myocardial infarction and less rate of major bleeding. I think these are two key points for patient to get benefit from transradial approach. A third point is that from RL cranial, there is a diminished blood flow in diagonal from RAD. So I think if you have a sufficient time after the procedure, maybe you need to restore the blood flow for the diagonal. Can you say
Yes.
a retrograde blood flow for the diagonal? Is that diagonal?
Yeah.
Right. So let's move to the epicaudal. Epicaudal. So typically epicaudal. So from epicaudal, typically angiographically, there is a very severe disease as a proximal circumflex with mild to moderate calcification, and 3 small branches taken from the circumflex, and the obtuse marginal looks very big. So Gerjan, you have pre-dilated small branch and check the IVUS for both circumflex
Yes.
and obtuse marginal. So what's your next step?
Yeah, that's a great point. For this is circumflex and OM bifurcation lesions from the IVUS imaging give us more information because the OM is a very big vessel and distal circumflex is a very diffuse lesion and this is very small vessel, just a 2 millimeter millimeter diameter. So from this IVUS imaging, so probably we want to use the OM as the main vessel and the distal circumflex as the sign branch to do the two-stand technique for these bifurcation lesions. So from the IVUS imaging, we can see the distal and the circumflex. We can find the from the before the bifurcation, distal circumflex bifurcation, we can say that it's a relative the vessel, and I want to use it here to do the 90 zoom and check this the length is just 10 millimeters. So that's our next step.
For any given bifurcation lesion, if IVUS OCT is available on site, I think it will be very easy to calculate, to measure the vessel size, lesion length, and to guide the standing procedure. In a scenario wherein there is no intravascular image available, so I think a very simple way to follow the Morris formula to calculate the vessel diameter. This is same French guiding, so the obtuse margin looks like 3/0 of vessel diameter because there are 3 small branches taken from circumflex. So the right one looks like 2/0, middle one is 1.5, left one is 2.5. So in general, roughly, so the proximate vessel diameter for the distal circumflex would be 3.3 to 3.5 millimeter in diameter. So I think this is a very important finding, which is consistent with the IVUS measurement showing 3.5 millimeter in diameter. So typically angiographically, it's Medina 011 true coronary bifurcation lesion. So Dr. Gren, would you use obtuse marginal as the main vessel cell branch?
Yes.
Main vessel.
Yeah, main vessel from OM as the main vessel.
Okay, so what's the balloon size for pre-dilating small circumflex branch?
For the distal and circumflex, we use the 2.0
Two balloons. So
and here the balloon 2.
after pre-dilation using two semi-compliant balloons, so blood flow in the small branch looks like TB3.
Yes.
So what's your next step?
Yeah, from the IVUS imaging, the proximal, the circumflex with the calcification. So use the 2.5 specs angiogram. 2.5 the scoring balloon to pre-dilate proximal circumflex and the distal and then the circumflex or the OM, proximal OM.
How could you show the IVUS image for proximal circumflex to identify if there is a calcified nodule or the plug features?
Okay.
Yeah, this show the IVUS.
Proximal circumflex.
Yeah, this is the proximal circumflex.
So no calcified nodule. So from this slide, it looks like only 30-degree calcification.
Because could you find the calcification in the proximal here?
Yeah.
Oh, next slide. I think
The
next
calcification
slide.
angle not more than 180.
Yeah.
Okay, the typical calcification. Next slide.
Yeah.
Okay, this just move back. Just
Yeah.
backward.
It's
Too much. Okay,
Here.
Yeah. 180.
Yeah.
Yeah.
This is
but
18.
the lumen area is big enough. So after pre-dilation using scoring balloon for proximal circumflex,
Yes.
what's your standing bifurcation lesions?
Yeah. Based on angiogram and the IVUS imaging, we use the two-stand technique for this circumflex OM and the bifurcation, and OM as the main vessel, circumflex is the side branch, use a DK crush to do this bifurcation lesions. After the pre-dilation, I went to the advanced short stand in the circumflex. Okay, this is a stand. I will. Yeah.
So usually we prefer to use provisional standing technique for tissue left main bifurcation lesion. But for this case, because already was infected 1 month ago, so it means the circumflex will play a very important role in preventing ischemia. So the careful protection of any even small sub-branch from circumflex will be very important. Another point is that patient is 82 years old lady. So I think maintain the TIMI-3 blood flowing cell is the key, is our goal. The point is that according to our definition criteria, so the lesion according to the geography could be classified by Medina 011 with a diffuse lesion in side branch. So I think it would meet the criteria for complex bifurcation lesion. This is strong evidence, strong reason why you need to use two upfront two-stand technique. So in terms of the two-stand technique selection for real complex coronary bifurcation lesion with side branch diameter minimal 2.5 millimeters, DK quash was very well from our previous several clinical trial. So now you are using 3.0 by 10 so limousine routine scan inside branch, is that correct?
Yes.
And what's the balloon size in the obtuse margin?
Is 3.0.
3.0.
3.0.
Okay. After quash, after balloon or stent quash, I think the important point is the proximal circumflex looks like a larger than 4.0 millimeters.
Okay.
So it means we need to very carefully to perform post dilation using power balloon. It should be the power balloon should be 4 in diameter.
Great.
So this is the stem balloon, right?
Yeah, it's stem balloon.
Yeah.
To
So according to the standard of DK quash technique, after standing side branch, because the side branch stand is adjusted according to the distal circumflex size, so it should be undersized. It's small, much more small than proximal circumflex. So after stand, we need to slightly withdraw the stem balloon to optimize side branch stand. An alternative technique is to use another NC balloon to post-dilate side stand to make sure the side branch stand is the fully expanded, very well post. So now after standing side branch, Dr. Gudan, say you remove the side branch wire.
yeah, because it's very distal and move the wire and the stem balloon and use the vein vessel to crush this side branch stand.
So now you are doing first balloon crush.
Yes, this is.
So usually, before balloon crush, usually we don't need to remove side branch wire.
Yeah, usually don't move.
But it depends on the scenario. For this case, because the distal circumflex very severe disease looks very small. So during the crush procedure, if the wire moved forward too much, so it will be easily to get perforation or even dissection. So this is a thrill balloon, right? Thrill balloon.
Thrill balloon.
Okay.
And after crushing, and use the to rewire the side branch.
So what's the wire for side branch?
This is a run-through wire. Probably need to a new one.
Hydrophilic wire easily to get side branch to easily to rewire from the stance strap. As I said, because the hydrophilic wire is very sleepy, easily to get a more distal to get perforation. It's not rarely seen in some cases. So personally, I prefer to use silicone coated wire, which is very stable, easily to manage the wire to control its direction. So particularly for junior intervention cardiologist, if you use much more hydrophilic wire to rewire, there will be a high rate of complications. So I feel the wire from the prosim cell, but still some resistance. Some resistance?
No, I believe it's not.
Yeah, another problem is that because the proximal flex is very big.
Yeah, I think so.
So after balloon quash is a through.
Probably I use
so the
3.0.
proximal stand could not be well opposed.
Mhm.
So I think you need to use another
Yes.
3.5
35, yeah.
or even 4 balloon to do one more balloon quash. So it's
Yeah,
very
okay.
similar to this left main bifurcation lesion because the left main is pretty big. So even we use the small balloon to do balloon quash, it's not big enough to complete quash the side span. So I think a pot balloon is much better. Pot 3.0 by 6 do you have?
35.
3.5. Yeah.
Okay. Also, pot
6.
balloon is another new tool to do real pot. Because routinely after staining any vessel, so we need to do post dilation using NC balloon. When the NC balloon is closing to the proximal edge or distal edge, so it's call it pot proximal optimization technique. But so far from the commercial balloons for pot technique, the two shoulders, I mean proximal distal shoulders, along them even 2 or 3 millimeters, which will be very dangerous to get AG complication.
It's a pot balloon.
So therefore, this is why you need to design new pot balloon with a very short shoot, varying from 0.5 to 0.6 millimeter in length. So it'll be very easy. So during inflation, during pot, so we can directly put the proximal distal mark on the proximal distal edge to inflate the pot balloon at very high pressure. Also, it's very safe. Okay. So far, there is no any change of EKG or blood pressure line. Good. Patient does not complain any
No.
chest pain.
No, any chest pain.
I think after pot, it will be easily to revise some flash. Okay.
Okay.
So no dissection, hemi3 blood flow in some flash. The mainstream 360 platform is amazing to collect more live cases globally and to serve as a education platform to train, to educate junior intervention cardiologists.
It's
So
very easy.
1 week cases would be greater than the 4 days of live cases from any large conference. So now you have successfully rewired, right?
Yeah, it's right.
So it's very
rewire
easy.
is very easy because after the pot.
So completely balloon quash is very important. Good.
Sorry. Okay.
I should be very carefully.
Yeah.
This is a hydrophilic wire. So if you push the wire distally too strong,
这家
No, no, no.
it
Oh,
will be
KC.
easily to
KC.
get that section. So the OM balloon would be 3O. The side branch balloon will be another 3O and
Zero.
C.
230.
3O,
Zero.
Zero.
Yes. Zero.
short and long.
再来个3.0。
Short.
This is a 3O short port balloon.
It's not. It's not a
Or
polar.
conventional.
It's a non-compliant balloon.
3.0啥？
My team is very experienced in using decal quality technique, like Dr. Ge or Dr. Gao, so they can finish one decal quality cases in 15 minutes. So theoretically, conceptually, there are multiple steps for decal quality, but in fact, there are only 5 steps: standing inside the branch, balloon quality, rewiring, kissing, standing main vessel, final kissing, and the port. It's very easily. Another, I think the important thing is that we don't want to trade off between ischemia and the procedural cost. Even we need to use 2 stand for decal quality technique. There are several clinical trials from decal quality 1 to decal quality 7.
Yeah. Easy.
All confirmed the less rate of major cardiac adverse events during 1 to 5 years follow-up. Okay,
16.
so once successfully rewired, so this is not 3ONC balloon in that branch to do alternative inflation at 16 atmosphere, followed by alternative inflation in the obtuse marginal. Finally, post-kissing balloon inflation will be on schedule.
8. Okay, great.
So for any kissing balloon inflation, we always recommend to keep short overlapping of 2 balloons in the main vessel to rebuild the metal carina, which is very important to minimize to reduce the thrombosis. Okay. So after kissing balloon inflation, so I think the next step will be standing main vessel, standing obtuse marginal. So what's the extent size?
The 26. 3.
23.
Yes.
Looks like too big. So angiographically, I feel 3 by 18 is long enough.
Okay. Good. Okay. Stand. Okay.就这样的啊。
Why do you choose so long stand for obtuse margin? 3 by 23.
Because I need to protrude the main vessel and to get the out here.
I think
This
too much protrusion.
Okay.
Good. It's good.
Good. Yeah. Right.
After standing main vessel, you need to use a full NC balloon to push that leg again.
Okay.
So what's a stand brand? It's a sinus stand.
Final.
No, 5 Hawk. Microport. Yeah.
5 Hawk. So 305 stand is easily to get the final diameter greater than 4.5. No problem. So particularly for distal left main bifurcation lesion, if we use the 305 hawk from proximal ID to left main, so after using the 1 more 4 or 4.5 NC balloon to get the final diameter greater than 4.5. Important thing is that very less rate of stand fracture for 5 hawk stand from small diameter is shifting to the large size. Good. Approximate surface, there is a severe sparse. The patient is fine.
After main vessel standing, I use the port balloon to do the port for the proximal circumflex. So here is a port.
Yeah, another trick is that for this patient, because you also need another stand for proximal circumflex.
Yes.
Before that, if you did not do post dilation for the first stand, it would be very difficult for some cases to get two stands overlapping each other.
No, it's used. They use another non-compliant balloon. 305.
3.5的新的。
This is the 4.
Yeah, it's not for 305, but because they used, so it's not cannot cross. Use some. I think that use a new one.
Because the side branch wire still in the position.
Yes, I know.
Did you try to remove the side branch wire?
Yeah, after this, advance this balloon, and then move the wire.
Yeah, sometimes the side branch wire works as a anchoring wire.
Yes, give some support.
The main vessel balloon or main vessel stand. I should be very carefully because this is a hydrophilic wire in that branch.
Okay, move the side branch wire and to test to this port.
Only for proximal segment.
Yeah, okay. 6. 20, okay.
So the principle for the post dilation is that NC balloon distal mark on the NC balloon no more distal to the bifurcation area. So this is very important to minimize the client shift to avoid the vessel perforation. So if you pull the large NC balloon too distal into the obtuse marginal, there'll be at risk of intra-procedural complication. In our last years, I remember there are few cases who had the coronary perforation induced by the overaggressive dilation using a large NC balloon. I think it could be easy.
Yeah, easy, very easy. Here here advance the wire would be carefully.
So you still use 30 NC balloon for side branch?
Yeah, 230 part non-compliant balloon.
2个3.0的高压。
To do the final case information. Here is probably need some dissection in here. So very careful.
I think you can put wire on the left branch.
Yeah, I think so.
It looks like a big one.
Yeah, okay. Good. Yeah. 230.
So for NC balloon, sometimes during the procedure, we need to multiple use the NC balloon. So before insertion of the balloon into the guiding, we can we can reshape the NC balloon to decrease the entry profile.
Okay. Good. Okay.
No difficulty.
Yeah.
So no difficulty to get the balloon into the side branch. A very good point to show how to do decay quality in correct way. For some cases, for example, for patients including in our ongoing decay quality A trial, so after balloon quash, after standing
very easy.
just before rewiring that branch, we can use the IVUS to assess the real position of rewiring. So you are doing the final kissing.
Yes. It's
clearly.
Yeah.
Why?
Here's the sun branch post donate. Okay, wait a minute. Here, 18. Yeah, great.
Good.
Yeah.
So
here.
I always
And
say
before the final kissing.
kissing, so alternate inflection is very important. So starting from side branch, so we can understand that after post dilate inside the stem, so the client should be could be slightly swifted to the main vessel. And once we perform the balloon inflation in main vessel, so the shift will be back to its previous position.
Okay.
So the final kissing balloon inflation is to try to keep the client at the central position, not to shift to each other side. Go to real NC balloon. So the overlapping segment looks like a 4O, which is big enough for proximal third.
Yes.
So after final kissing and remove the wire for the side branch, I think you can use find the last stand, third stand for proximal third. So what's the stand size? Did you define?
Just 305.
3.5?
3.5, 18.
18? I don't know. 18 is not enough.
I think I need to
Check IVUS.
to recheck the IVUS.
Yeah.
Okay.
To measure. Not yet.
Wait a minute.
Because this is the AV caudal, so the proximal circumflex was shortened too much.
Yes, good.
Take a photo. Good.
Yeah.
No distal complication. So you tried to use the long stand to overlap with the first stand.
Yes.
So
use IVUS to measure
from the proximal stand edge to the ostium of circumflex.
Yeah.
This is also very challenging case. 1 month acute myocardial infarction and the primary PCI.
Incident. Okay.
Calcified proximal circumflex.
I will put back.
And the
Okay.
bifurcation.
Instant.
Then is expanded very well.
Yeah.
But looks like a lobulous size. So the vessel diameter, it looks like 1, 2, 3, 4, 4.5.
4, yeah.
More than 4.
So I think if out of stand, you need to use a 4O and C to post dilate.
Yes.
This is midi dissection.
Yeah.
The type A dissection.
Yeah. This is a proximal circumflex. This is LAD. This is the POC.
Okay.
Okay, I will stop.
So there is a very short landing zone as a very proximal circumflex.
Yeah, correct.
So
Then that's 17.
17.
17.
17. So I think 18 millimeter is
Yeah.
long enough.
18.
18.
35,
18.
35, 18.
So 1 millimeter overlapping with the first stem, not long enough. I think you don't need to use a second wire in the flex.
No, I just want to use wire into the LED. Okay.
So angiographically, oxygen LED looks like normal.
Yeah.
And then nothing there because the LED is infected 1 month ago. So if the flex stent does not protrude into the left main, I think it will be very safe.
Yeah, but this why maybe give some inch to position this proximal circumflex standing.
So 3.5 stent post dilate by 4.0 NC balloon. This is because they change of calcified plaque after modification. So for some cases, if the vessel lumen is big enough, usually we don't treat the proximal calcified lesion at first. I think you can pull the wire more distally.
Oh, you did draw. Oh. Okay. 你看看病人来，看看病人谁去看看病人。
I think I need to move to side view.
Yeah. 18? Oh.
Side view.
Good. Yeah, test. Sydney. Good. I think it's a good position.
Good position, very good. 1 millimeter overlapping. Very precise. Very, very.
去买别说，蛮好。Good. Good. OO non-compliant balloon. 4.0的短高压。
I think you can use 4.0 by 12 or 15. 4.0、12或者15的后扩都可以。Okay. So after post dilation, I think we need to check the IVUS to identify the protrusion into the just left main and the stent expansion.
Wow. 12? I think the baby is born.
Difficult?
Yeah, I think the baby is full line, but
This is because of the angle.
yeah.
Okay. 下面。
Go. Okay. Here. Let me protocol.
How much is the inflation pressure?
12? 10. Yeah, 12. Yeah, okay. Good.
pulse dilation from distal to proximal.
Yeah, okay. Okay. Here, okay. Test a little bit. Good. Okay. Great.
Sure.
Yeah. Okay. Mhm.
So can you move to epicaudal?
Yeah.
Because the
The anchor central.
yeah,
back.
proximal segment to the bifurcated area. I think you need to push the balloon more distal to the segment proximal to the bifurcation. Easy to go.
It's not easy to go.
Test. More
Here,
distal.
yeah, well, it's not easy.
Yes.
Yes. Because too long. Oh,
Good.
good. Okay. So, good. Okay.
So there are two angles
Yeah.
for proximus and flex.
Yeah. That's okay. Good.
Because there is almost 180-degree classification.
Yeah. So
the
it's
process.
anchor central back. So
So I think we can recheck the IVUS to see if there's a need of additional pulse dilation. So we still have 5 minutes.
enough.
Right.
Yeah.
Yeah. Is micro?
So the hydrophilic wire is still in RAD. I suggest a little bit withdraw. Slightly move the wire from RAD
Okay.
Okay.
because it's too sleepy.
Good.
The IVUS is in OM or circumflex.
OM.
Okay.
Here. What is?
Yeah.
Yeah.
Okay. I
Yeah.
will pull back. It's the OM. The normal.
So
That's all. It's 3-0.
distal is 3-0.
Yeah.
0.
Little bit larger than 3-0.
The
Okay.
distal stand
This
edge
stand
is normal.
It's beautiful.
No
Not
dissection.
normal. Beautiful. Distal stand.
Then
is,
diameter distal is maybe
yeah, is,
2.5.
Right.
Not very large.
The distal segment.
This is a bifurcation.
Yeah. Yes. Yeah.
Stand crinal is in middle.
You can see.
The proximal segment looks good.
Yeah.
It is almost a 3-5 because this is 3 stand. 1, 2, 3, 5. 3, 5. Very close to 4.
Yeah. Use the 4 post dilation.
It is a 3.5. Good.
Yeah. Oh.
So this is the 2 layers of scan.
Yeah, maybe
Yeah, probably.
double layer.
2 layer.
Oh, here is.
The proximal stand.
Nice. Looks very well. The proximal.
Near the ostium.
Okay, good.
Okay.
Okay.
Yeah.
Very precise position. So what's a minimal scan area for proximal simplex and for obtuse marginal? 各一类
The distal scan just 4 millimeter
他们
square.
use
let's say not big enough.
yeah use 3O non-comparable to push that short, very short.
Proximal circumflex area is about 9.3 millimeter square.
Proximate is big enough.
Yeah.
Also, almost there is no any protrusion.
Yeah, that's all.
Okay.
So finally, I use the 3O short balloon to do the post dilator for the main vessel. Okay.
So panel, can you tell Dr. Jim
Where's the
what's the difference between the minimal stent area to the distal stent edge? What's the length? What's the distance? No, proximally.
The
The distal edge.
distal
distal
edge,
edge? Yeah, yeah.
How long distance? 3 or 4 millimeter?
4 millimeter.
4 millimeter.
Let me see.
Okay.
Test a little bit.
So you can
Yes.
pull the NC balloon very close to the distal edge.
Oh, here you can see from the angle. Okay. What's that?
This is a 3O.
0, yeah. 16. Good.
Very good.
Mm.
So after post dilation, we need to have IVUS image again.
Yeah. Test. Okay. Start.
2 minutes left.
Yeah. Okay. Yeah, I'm ready.
Ready.